So I'm going to introduce Herbert Kempf, who is assistant professor at the University of Lorraine in Nancy, France. And he has a strong developmental biology background, who is now interested in vascular physiology, and is studying a very interesting model, which is the MGP knockout model of vascular calcification. So he's also going to teach us about how calcification progresses in different compartments of the vasculature. Herbert, pleasure having you.
You hear me? Yeah. Okay. Thank you very much, José Luis. I'm very impressed to be here, actually, and I thank you for inviting me and for giving me the opportunity to share with you a little bit of the work that we are doing right now in my group regarding aortic calcification, and as José Luis said, especially dealing with the MGP knockout mice. So we're going to go back to basic research, no clinic at all. So I have an introduction about vascular calcification, even though before you heard a little bit about it. So vascular calcification are, can I see something on my computer or not? No?
You can use the mouse to point.
Okay. I don't see anything about the computer. Okay, thank you. So vascular calcification are common clinical complications in the elderly and of several pathological conditions such as atherosclerosis, diabetes, hypercholesterolemia, and chronic renal insufficiency. And as you have seen also, they can be observed in rare diseases as well, such as PXE, Singleton-Merten syndrome, ACDC, etc. They are associated with risk of amputation in diabetic patients and are significant cardiovascular morbidity and mortality. And they are due to the abnormal deposition of hydroxyapatite crystals in the vascular wall of various vessels. For a while, this calcification process was thought to be a passive process, but for the last maybe 2 decades, a growing list of inhibitors and activators of this process were found. And here it's just a little bit of a small list of inhibitors, and especially pyrophosphates that you heard a little bit in the former talk, and also the matrix GLA protein that I'm going to talk about, and activators like the alkaline phosphatase that you also have heard a little bit in the former talk. So in the vasculature, the hydroxyapatite crystals can appear both in the intima layer or in the media layer, depending on the pathology. So here I actually summarize what was thought, or what is thought to happen during the vascular calcification process, and its relation to developmental osteogenesis. So calcium deposits are observed consist of hydroxyapatite crystals, the same mineral as in bone, rather than amorphous calcium phosphate. We can also observe in artery walls of experimental animal models and human patients cartilage, endochondral ossification, and even bone formation. In situ hybridization and/or immunostaining studies of calcified lesions showed expression of bone morphogenetic protein type 2, I will come back to that later, which is a potent osteogenic differentiation factor, as well as chondrogenic and osteogenic specific transcription factors such as SOX9, RUNX2, or MSX2. And it's important to know that smooth muscle cells, vascular smooth muscle cells, have the ability in vitro or in vivo to undergo phenotypic changes. That means the differentiation, transition, transdifferentiation, you name it, into a large number of cells types, including chondrocytes and osteoblasts. So smooth muscle cells transition to chondro-osteoblast-like cells by a BMP-dependent mechanism is thought to be regulated by transcriptional pathways similar to those used during embryonic bone formation. So what's happening during the embryonic formation? Actually, a mesenchymal cells can go into 2 different pathways. The first one is the endochondral ossification pathways, which give rise to chondroblasts first that are eventually replaced by bones to form, by osteoblasts, sorry, to form bones. And the other pathway is intramembranous calcification, which actually give rise from mesenchymal cells directly into osteoblasts. So what is thought during vascular calcification is that depending on the pathological condition, the smooth muscle cells will actually undergo either of these pathways to form osteoblast-like cells that eventually will mineralize in the vascular wall. And these pathological conditions are actually numerous. So we talked about genetic diseases like Singleton-Merten, ACDC, PEX, etc. But you can also find a vascular mineralization during chronic kidney insufficiency, and the risk factors are actually shown here. You can find vascular calcification, as I said, in diabetic patients, and the risk factors are shown here, and also during sclerosis. But what struck me when I started in this field was actually that depending on the pathological condition, the vascular mineralization process takes place in different regions of the vasculature. For example, here in a diabetic patient, peripheral arteries are affected. In an atherosclerotic patient here, the coronaries are affected. In genetic disease like ACDCs, you have shown before, only the leg vasculature is affected. In Singleton-Merten, which is a very rare disease, all the patients actually show calcification in the ascending aorta or the aortic arch, and also in some part of the descending aorta. So as a developmental biologist, I was really puzzled by this. And we know in developmental biology that all vessels are not created equal, meaning that they actually comes from different embryonic origins. Oops, sorry. And if you focus just on the aorta, okay, I actually put into colors regions that of these vessels that comes from different origin, embryonic origin. So the red and the orange part of the aorta actually come from mesoderm, whereas the blue part, which is basically the aortic arch and the carotids, etc., comes from neural crest. So I had this simple question, which was that does the embryonic origin of the vessel, and in that particular case of the aorta, has an influence in the vascular calcification process, sorry. So we focused on hyperphosphatemia, which is very well known to induce calcification. And we used ex vivo and in vitro experiments in normal and in high phosphate condition to look at the calcification of this different region of the aorta. The first type of experiment that we made were actually very simple. We dissected out explants that encompassed the aortic arch region or abdominal region. And we put them into a culture with or without high phosphate condition. And here you see the control that never actually calcified even after almost a week of culture under 1 millimolar phosphate condition. But when you put this explant under high phosphate condition, which is here 5 millimolar, we got exactly the same result with 3 millimolar, actually. You'll see later. If you put the aortic arch in this condition, already a day later, you can start to see patches of calcification appearing in this explant, whereas you can never see it in the abdominal aorta explant. After day 3, the aortic arch starts to be completely or almost completely calcified, and at day 6, the calcification process is complete, which is actually also the case at day 6. But you never see any calcification. We have never seen any calcification process in explant culture with 5 millimolar condition in abdominal aorta. And we did also a quantification of the calcium content of this explant, and we got exactly the same results. Sorry. So the conclusion of this experiment was that the aortic arch calcifies earlier than the thoracic aorta, and that the calcic deposition is significantly higher in the aortic arch. So we did exactly the same experiment, but this time we actually did cross sections, and we did a von Cossa staining. Just to be sure that what we have seen was actually not due to the high phosphate that we had in the medium. And I'm not going to go into details with these figures, but basically we got exactly the same result, which is that high phosphate conditions lead to medial calcification, and there is a delay in calcification appearance when you compare abdominal aorta or even proximal aorta, which is also from mesoderm origin, compared to the aortic arch. So because we know that smooth muscle cells are the cells that actually calcify in the media, we did exactly the same result, the same experiment, sorry, and obtained the same results when we harvested smooth muscle cells directly from the explant that we put into culture. So here, D crest means smooth muscle cells derived from crest or from aortic arch, and D meso means smooth muscle cells derived from abdominal aorta explant. And we obtain exactly the same result, which means that after 1 day in culture, under high phosphate condition, we start to see calcification patches in the culture, which was never the case in mesoderm-derived smooth muscle cells. Sorry. So again, what we have shown here is that smooth muscle cells derived from crest origin, meaning the smooth muscle cells that are in the aortic arch region, calcify earlier than mesoderm-derived smooth muscle cells. So then we wanted to see if what we have seen in culture was actually true in vivo. And I had the chance to have, or to know Gérard Carcenti, and he was okay to give me the MGP knockout mice. So just a slide to introduce matrix GLA protein. The matrix GLA protein is a member of the GLA protein family, including coagulation factors 7 and 9, and also osteocalcin, which is also known as the bone GLA protein. It is a short protein of 84 amino acids that contains 5 gamma-carboxyglutamic acid, called GLA, residues produced by vitamin K-dependent gamma-carboxylation. It's expressed in kidney, lung, heart, but most importantly in cartilage and smooth muscle cells of the blood vessel wall. It binds calcium ions and calcium-containing crystals like hydroxyapatite through the GLA residues. It also binds to BMP2, and if it binds to it, it antagonizes its action. The pharmacological inhibition of matrix GLA protein through anti-vitamin K treatment, like warfarin treatment, induce vascular calcification. And something which is actually weird and that we don't really understand yet is that MGP mutations are responsible for the Cuttle syndrome with a lot of ectopic calcification, but not in the blood vessels. So we don't know, except one case. One case, the first case actually that postmortem was actually, they could identify some vascular calcification. So MGP knockout model was actually done almost 15 years, more than 15 years ago by Carcenti's group, and shown that the matrix GLA protein is a very strong calcification inhibitor. In this knockout mice, cartilage are calcified, but also arteries. Here you can see the whole arterial trunk mineralized and visualized by alizarin red staining. This calcification appear in the media of the vessels and are spontaneous. And the MGP homozygous mice actually die between 4 and 8 weeks due to aortic rupture and hemorrhage. The MGP heterozygous mice never calcified spontaneously. So we took this model and we actually revisited this model. And because we wanted to know when the calcification appeared and how they progressed. So here it's summarized on this slide. We actually looked by alizarin red staining at the calcification process starting at P0, so just after after birth, and we looked for the last 3 weeks or a month, and we can see that in each individual without the MGP gene, we can see that patches of calcification appear at P4 in the aortic arch and never in the abdominal aorta region. And then after a week, this calcification progress throughout the abdominal aorta and start to be completed around 3 to 4 weeks. So in this model, only, we found that MGP knockout start to calcify at P4 and that these calcifications are always initiated in the aortic arch. So then we ask, because usually what I've showed you before is that usually when you talk about vascular calcification, you talk about smooth muscle cells transition into chondroblast or osteoblast-like cells. So we knew, because of other publications that, and we never found any actually, that there were no osteoblast-like cells in the arterial wall of the MGP knockout mice. But it was actually published that there were chondroblast-like cells in these mice. So we thought that the chondroblast might be involved. So we looked at the cartilage formation in these MGP knockout mice. And we were very surprised because we never found any cartilage markers such as, sorry, I lost it, such as SOX9 or collagen 2 at the day where calcification start to appear, the patches of calcification that we have shown by alizarin red staining. And that SOX9 and collagen 2 actually start to be expressed only after 3 weeks after birth. We had the same result when we looked by in situ hybridization. You can see here in a wild-type mice that smooth muscle 22, which is a smooth muscle marker, is expressed in one of the vessels, and that collagen 2 is not expressed in these vessels. Here it's a trachea, which is a perfect control for collagen 2-1 expression. But in the MGP knockout mice, where you can see von Cosa staining, so calcification appeared in these vessels, you can see that smooth muscle 22 marker is actually absent and is replaced by collagen 2 expression, meaning that at 3 weeks, because it was a 3-week specimen, at 3 weeks, like we have seen by qPCR, smooth muscle cells are actually transitioned into a cartilage phenotype. And we have shown the same thing in terms of proteins. So how can we explain that we got calcification in MGP knockout mice at P4 without any osteoblast or chondroblast differentiation? So we went back to the embryo and to this very, very elegant paper. I don't say that because you're in it, but it's very elegant paper and very seminal for us, which shows basically that to get mineralization, you need to have co-expression of alkaline phosphatase and of fibrillar collagen. And that's actually, vascular wall is actually full of fibrillar collagen. So we wonder if alkaline phosphatase was actually upregulated in the MGP knockout mice. So we did a lot of RT-PCR from individuals where we actually dissected out only the aortic arch or the abdominal aorta. And we can show here that at the time where calcification patches start to appear, alkaline phosphatase starts to be upregulated. And when a calcification progress, or at least start to progress, alkaline phosphatase is also elevated, which is not the case in the abdominal aorta at the same time. We looked by in situ hybridization, and we also showed that we confirm that actually alkaline phosphatase expression is actually correlates or is expressed in the same region where we can detect von Kosa staining, and where smooth muscle cell markers, smooth muscle 22, start to be disappearing. So my conclusion is that under hyperphosphatemic condition, the aortic arch calcifies earlier than the descending aorta. Then crest-derived smooth muscle cells are more prone to become calcifying cells than mesoderm-derived smooth muscle cells, which means that smooth muscle embryonic origin correlates with the appearance of vascular calcification, and that alkaline phosphatase might be a key factor in the initiation process. How long do I have more? 5 minutes? So I'm not going to be able to show you everything, but so what we think, at least for the initiation process in these mice, is that because there is no MGP protein produced by the smooth muscle cells, and because MGP is an inhibitor of BMP signaling, the BMP signaling is going up in these mice, and that BMP signaling is actually, and it has been shown in different other models, that BMP is actually upregulated alkaline phosphatase, which in turn increase the phosphate-pyrophosphate ratio. So it increases phosphate and it decreases pyrophosphates. So I'm going to go. We also have, because I don't have much time left, we also have a model now, and I have no time to show you all the results, but where for the progression, we think that it's actually going the same way. And we have shown that actually increasing phosphate in smooth muscle cells induce the expression and the activation of the BMP2 signaling pathways, which in turn, it's like a vicious circle actually, increase alkaline phosphatase expression and then increase the phosphate to pyrophosphate ratio. And we also think that this increase in BMP2 expression induce cartilage formation. It might also be related to alkaline phosphatase expression. There might be a role of alkaline phosphatase in cartilage formation from smooth muscle cells. So what we think now is we would like to try if we are right and if alkaline phosphatase is very involved in the process of calcification in the MGP knockout mice, we like to try therapeutic strategies. Of course, we can use pyrophosphate to inhibit or to balance the ratio that we have seen unbalanced in the initiation process in the MGP knockout mice. We can also use BMP inhibitors because we have shown that BMP is very important, but our preliminary data show that there are different BMP receptors which are actually involved in the initiation process and in the progression process, so it might be difficult to have the right inhibitors to use. So now we are thinking about using alkaline phosphatase inhibitors that have been, for the most part, done by José Luis to try to see if we can actually delay or even rescue the vascular calcification phenotype in the MGP knockout mice. So I want to finish by acknowledging all the members of my group. So this work I've started when I was still in Paris, especially with Thiago Maciel and Margot Leroux-Berger, a Ph.D. and a postdoc. And I'm keep on working on it with my new group now in Nancy, and especially with Catherine Isidorzik and Nina Tapche. Thank you for your attention.
Questions?
do you actually see the chondrogenic formation before the onset of calcification?
Before?
Before the onset of calcification?
No, that's what I said. I mean, we've never seen any cartilage formation before the onset of calcification. We've seen it after 3 weeks only. That means that there is at least a 2 weeks delay between cartilage-forming cells and the first appearance of calcification patches.
So the chondrocytes appear at the same time as the calcification does?
No.
Later?
2 days later. 2 weeks later, sorry. 2 weeks later. That's why we think that it's completely independent. Okay. And that maybe actually alkaline phosphatase might have a role in the transdifferentiation of smooth muscle cells into cartilage cells, but cartilage cells are not involved in the calcification process. Neither osteoblast actually. It would be only TNAP dependent, but cartilage and bone independent.
Yes, please, go on.
I'm curious about your hypothesis suggesting that the neural crest versus the mesenchymal cells are the critical issue here, and I wondered if you had considered whether something mechanical about the upper aorta versus the abdominal aorta is potentially resulting in a more susceptible vessel.
Yeah, you're right, actually. I focused here on the embryonic origin of the smooth muscle cells, but we cannot, how can I put that? Of course, calcification of the smooth muscle cells are a combinatorial effect, I mean. So we think that hemodynamic might have a role. We think that hypoxia might have a role. We think that, I mean, and if we are in a diabetic patient, for example, hyperglycemia might have a role, etc., etc. I think that's a combination of all these factors that have a role into the vascular calcification process. So what we show here and what we think is that embryonic origin is one of these factors, okay? But on the other hand, in the MGP knockout mice, we think that hemodynamic has no role at all because we never seen any calcifications or early calcification in other bifurcations, in bifurcation of the arteries, for example, in the iliac or femoral arteries, even though there is hemodynamic factor which might be a little bit similar to what's happening in the aortic arch. Okay, but we think that hypoxia might have a role because we have never seen any calcification before birth. It always happened at birth. So we are actually dealing with this hypothesis now, and we have shown that hypoxia is very relevant in terms of a factor, a combinatory factor in calcification, in the calcification process.
Thank you, Herbert. We need to move on. Thank you very much. So I'd like to introduce Dr. Frank Rusch, who perhaps is the person that has the most experience with GASI patients in the world, who is going to give us a clinical perspective of these types of symptomatology.
Would you like to use the podium or would you like to use it?
I can use this.
Okay.
I'll just load it for you real quick.
Okay, I'm really glad to be here. This is not the first time I am in San Diego. I've been here before, like about 12 years ago, and I'm very happy to be here again. This is the place I work in Münster. That's the University Hospital of Münster, and I'm working in the basement of one of these big towers. It's not here somewhere. It's not the hospital is not only for children. Its main building is for adults, but the left part, the west tower, is mainly for children. And I'm working on this rare disease called generalized arterial calcification of infancy because I met this patient when I was working in another hospital before I came to Münster. And this is Mustafa. And Mustafa on this picture is 3 years old, but I know him since birth. And he was born to consanguineous Turkish parents. And the mother was 37 years old when she already had 3 previously stillborn children and 2 previous abortions. Mustafa was born as a premature infant at 36 weeks of gestation, and while he was quite healthy at birth, he developed cardiac failure at the age of 5 days, and this was the initial X-ray, and here you see that the heart is enlarged, and he was already intubated and ventilated, and at this time we didn't know what the reason for his cardiac failure was. Then he developed arterial hypertension at 4 weeks of age, which was very unusual. This is a Doppler sonogram of his right renal artery, and you see an increased, I don't know where the pointer is. You see an increased blood flow through the right renal artery. And later we did an angiography. This is an MR, magnetic resonance angiography, and we found that the right renal artery is actually very narrow. So there's a stenosis here, and also there's some stenosis on the other side, which you cannot see on this picture very well. So he had bilateral renal arterial stenosis and arterial hypertension. And we still didn't know what the underlying disease was. But then at 8 months of age, he developed periarticular calcifications. And here you see a picture of the hands showing calcifications here at the ankle, at these bones here, and also at the ankle of the foot. He has periarticular calcifications. At that time, a cardiologist of our hospital thought, well, this might be generalized arterial calcification of infancy. And when we looked back to his initial X-ray, we were actually able to see faint calcifications here. There is a line, a parallel line of calcifications at the abdominal aorta. And then we went also back to the initial ultrasound of the heart, which was done at in the neonatal phase. And we were also able to see a really echogenic aortic arch, which was initially considered, but then not really noted on the initial ultrasound of the heart. So the combination of periarticular calcification, renal artery stenosis, and the aortic calcification made the whole picture to let us believe that this child has generalized arterial calcification of infancy. And we prove the diagnosis by doing a biopsy of the temporal artery, which showed the classic calcification of the lamina elastica interna, which is shown here on a von Cossa stain, which is associated with intima proliferation, leading to a narrowing of the lumen of the artery. So this child clearly has the disease. And then so this is the picture of the disease. You have periarticular calcifications. This is another infant showing large calcifications at the elbow joint. And this is a CT scan of a patient at the age of 1 week. Usually on a CT scan, on a native CT scan, you do not see the vessels at all unless you give contrast media. And this is a picture without contrast media showing calcification of the whole aorta and the iliac arteries bilaterally. In this disease, as I told you, you also have stenoses, and these stenosis, if they are located at the renal artery, lead to arterial hypertension. If you have stenosis of the coronary arteries, like in this patient, which shows a picture of the left coronary artery, if you have a stenosis there, that can lead to myocardial infarction in infancy. And this child who had this stenosis died at 48 days of a myocardial infarction. You see at the tip of the left ventricle an infarction here, which led to death in this infant. This, by the way, is a section of the aorta, which is also thickened in this infant. The molecule which is important for the disease is pyrophosphate. And this is the chemical formula of pyrophosphate. And pyrophosphate is interesting because it's inhibiting the precipitation of calcium phosphate. And it is also added in toothpaste to inhibit tart formation of your tooth. So it's a mechanical agent which inhibits the precipitation of calcium phosphate and the turnover of amorphic calcium phosphate to crystalline hydroxyapatite. And we became interested in this molecule because it has been shown in one patient in a paper of in the 90s that it was low in plasma in one patient. And we also looked at pyrophosphate in Mustafa's plasma, and we also looked in the urine of Mustafa for pyrophosphate, and we found that pyrophosphate was low in the plasma and in the urine of our patient. And this was the time when we started to look how is this the metabolism of pyrophosphate organized. So pyrophosphate is in the extracellular space inhibiting hydroxyapatite crystal formation, and there were at this time 3 molecules known to be associated with pyrophosphate metabolism. This was TNAP, the non-specific alkaline phosphatase, the ANC protein, and ENPP1, the ENPP1 enzyme. So ENPP1 generates pyrophosphate by degrading ATP and GTP. And ANC is a protein, a membrane protein, which shuttles pyrophosphate from the intracellular to the extracellular space. And then there's TNAP, the non-specific alkaline phosphatase, which degrades pyrophosphate to phosphate. We measured TNAP in our patient, and it wasn't changed. But then we thought, well, maybe it's a deficiency of ENPP1, which causes the low extracellular pyrophosphate levels. So if you have a deficiency in ENPP1, the extracellular pyrophosphate levels should be low, and the inhibition of hydroxyapatite formation is blocked, so you have more hydroxyapatite. And this was the time when I came to San Diego in 2001, working with Borg Terkeltaub in the Terkeltaub lab, which is just somewhere around the corner here. In the background, you might see Kristen Johnson, who has been working with him. Some people may know her. She's the one who did the pyrophosphate assays. So this was the place where I was sitting and working on this disease here in San Diego. And what we found is that NPP1 was deficient in plasma, in Mustafa's plasma, compared to unrelated control children. If we did an ELISA, we found it's not measurable, and the activity was also low compared to unrelated control children. So there's a deficiency of NPP1 in plasma, and also you can find the same in fibroblasts in this disease. So there is a natural occurring mutant of ENPP1 deficiency, and this is the tiptoe walking mouse. The mouse has a truncating mutation of ENPP1, and because of this, the mouse has calcifications of the ear cartilage and calcifications of the perispinal ligaments. And because of the calcifications of the perispinal ligaments, the mouse is walking on their toes and on their tiptoes, and this is why the mouse is called tiptoe walking. So this is the tiptoe walking mouse, and we knew there is this mouse model having mutations with a phenotype which is a little similar to what we have in our patients. And we were able to show that this mouse also has calcifications of the media, and this is Ivan Nitschke, who does some mouse work in my lab now, and so you can easily see that these calcifications in the aorta of the tiptoe walking mouse. Mustafa then was shown to carry the E893X mutation in the ENPP1 gene on both alleles. And meanwhile, we have collected patients from all over the world, now more than 100 patients with generalized arterial calcifications of infancy. And we did mutation analysis of the ENPP1 in the ENPP1 gene, and up to this date, we have discovered more than 50 different mutations located all over the gene in this disease. Interestingly, in generalized arterial calcification is another thing which we found, and this is renal phosphate wasting. We have strikingly seen that some of the patients developed phosphate diabetes. So they throw out their phosphate through the urine, and the rate of phosphate reabsorption is decreased the older they get. So it seems that renal phosphate wasting is somehow maybe compensating the disease state. And there's another thing which is interesting to know, and this is the bisphosphonate story. So bisphosphonates are synthetic analogs of inorganic pyrophosphate, and it might be reasonable to think that these drugs could be used to treat a deficiency of pyrophosphate. And if you look at the overall survival of patients with generalized arterial calcification, it really makes sense to treat these patients, because more than 60% of the patients die within the first weeks of life. So at the age of 10 months, there are only less than 40% alive in the overall survival with generalized arterial calcification of infancy. We did a retrospective study on the patients we knew with this disease and looked which patients have been treated with bisphosphonates. And if you compare this, you will see that if the patients who were treated with bisphosphonates have an increased rate of survival. So 70% of the patients who were treated with bisphosphonates within the first year of life survived the first year, while the untreated patients had a greater rate of death within the first months of life. These results have to be interpreted with care because it's a retrospective study, and it might be that patients who were treated with bisphosphonates were initially better off than those who did not have the chance to be treated because they were so sick. The latest thing we did was looking at patients who do not have mutations in ENPP1. So at that time, we had 92 patients with generalized arterial calcifications. We had 62 patients whom we were sure to be carriers of 2 NPP1 mutations. So we had a causative gene for these, but there were 30 patients where we did not have a causative gene for the disease. And to get an idea what other gene might be involved, we were helped by Ludovic Martin from France. And he had an interesting family of 2 siblings, and one had pseudoxanthoma. This is the one on the right, on the left side of this picture. And this patient had a brother who died, and the patient who died had arterial calcification in infancy. You know, maybe pseudoxanthoma elasticum. This is another rare disease where you have calcifications at the Bruch's membrane of the eye, leading to visual problems and the so-called angioid streaks, which you can see at the back of the eye. In pseudoxanthoma elasticum, you also have calcifications of small renal arteries, and you have calcifications of the skin, which gives you the typical peu d'orange phenotype. So we had this family where we had like both diseases in one family, the pseudoxanthoma elasticum in the elder brother and arterial calcification of infancy in the younger brother. We knew that pseudoxanthoma elasticum is caused by mutations in ABCC6, and in this family, Ludovic Martin was able to show that the elder brother had mutations in ABCC6, but the younger brother, unfortunately, we didn't have any DNA to look if this younger brother also had mutations in ABCC6. But because we had this family, we thought, well, it might be a good idea to look for ABCC6 mutations in our patients with generalized arterial calcification in infancy where we did not have ENPP1 mutations. And that's what we did, and this is a schematic scheme of the ABCC6 protein, and we actually found 12 mutations in ABCC6 in our patients with generalized arterial calcifications of infancy. These red ones are mutations which we've only found in our GAZI patients and which have not been described in patients with pseudoxanthoma elasticum. So in 8 patients of our 32 patients, we found these mutations on both alleles, and in 6 patients, we found mutations only on one allele. Calcifications, there's also a mouse model for ABCC6 deficiency. This is the discalc mice, and these mice carry a splice variant of the ABCC6 gene, and they also have calcifications in the renal vessels and in the myocardial arteries and in the cornea. So this calc mice recapitulates the phenotype of the PXE. So we have seen now that mutations in ABCC6 can cause generalized arterial calcification of infancy. But then we also have another striking patient. And this patient had calcifications of the aorta when he was an infant, and he later, at the age of 8 years, developed the pseudoxanthoma and calcification of the elastic fibers in the skin, which was proven by histology. And this patient did not carry mutations in ABCC6, but this patient carried a mutation in ENPP1. So ENPP1 in this case caused generalized arterial calcification and pseudoxanthoma elasticum. And we have another patient also identified by our French colleagues who had periarticular calcifications in infancy, and the angioid streaks of pseudoxanthoma elasticum, and this patient also carried mutations in ENPP1. So what we can propose is that there's an overlapping phenotype in generalized arterial calcification of infancy and pseudoxanthoma elasticum. Mutations in ABCC6 can cause the typical generalized arterial calcification phenotype and the pseudoxanthoma elasticum and the periarticular calcifications, and also mutations in ENPP1 can cause the generalized arterial calcification of infancy and the calcifications of the skin and periarticular calcifications. And it might be that there is an overlap in the clinical spectrum of generalized arterial calcification of infancy and of pseudoxanthoma elasticum. So there is an infantile type of ENPP1 associated generalized arterial calcification of infancy, which starts in utero and has its main manifestations in infancy and childhood. And there is an ENPP1 associated pseudoxanthoma elasticum, which also starts in infancy and later develops into childhood and adulthood with calcifications of the eye and the skin. And then there is the classic ABCC6 associated pseudoxanthoma elasticum, which has no manifestations in infancy, but later develops in childhood and adolescence. And then there is the new ABCC6 associated generalized arterial calcification of infancy, which is a severe disease leading probably to death within the first months of life. There are still open questions which have to be solved, and I think there are many here in the room who work on this. So one question is, what is the shared pathogenic pathway of ABCC6 deficiency and NPP1 deficiency, and what are both regulated by each other? So does NPP1 regulate the expression of ABCC6? And of course, which other genes are involved in generalized arterial calcification? So we still have some patients where we didn't find mutations in ABCC6 or in ENPP1. And finally, of course, what is the substrate of the ABCC6 transporter? It might be that ABCC6 is a part of this complex pathway here. And one hypothesis would be that maybe ABCC6 is a transporter for inorganic pyrophosphate. But this is not known yet. So to sum it up, a generalized arterial calcification of infancy is characterized early calcification of the lamina elastica interna in the arteries by arterial stenosis, hypertension, and periarticular calcification. Hypophosphatemia and bisphosphonate treatment are associated with long-term survival in these patients, and mutations of ENPP1 cause low extracellular pyrophosphate levels, and these are found in about 75% of the patients. And mutations in ABCC6 are found in about 10% of patients with generalized arterial calcification of infancy. Mutations in ENPP1 and ABCC6 can cause both generalized arterial calcification and pseudoxanthoma elasticum. And with this slide, I would like to thank all the collaborators, including Bob Turkeltaub here in San Diego, the French Ludovic Martin and Gahl Boulanger from Angers, and Geneviève Beaujard from Paris, who contributed the PXE patients. And I would like to thank you for your attention. And this is a picture from Münster in Germany. This is located in the north of Germany. Thank you.
Michael?
Thank you for a beautiful review. Curious to know, do the patients with GACI or with pseudoxanthoma elasticum ever develop cerebral aneurysms? The reason I say that is there's an entity called juvenile Paget's disease, where most cases are due to deficiency of osteoprotegrin. That leads to enhanced rank ligand, rank signaling. But to go to a bottom line, this is the human disorder with probably the greatest rapidity of bone turnover, and with it comes the highest serum alkaline phosphatase levels that you can encounter. So in that disorder, you've got lots of alkaline phosphatase. Now you've lowered pyrophosphate levels, and these folks develop vascular calcification. They'd go blind from calcification in Bruch's membrane, but they also manifest occasionally big aneurysms of the internal carotids. So there's parallel in the pathogenesis and almost in the phenotype. That's why I was asking the question. I guess the second quick one would be, do either of these entities, or does pseudoxanthoma elasticum ever result in phosphate wasting?
Okay. Interestingly, regarding your first questions, the patients with generalized arterial calcifications never have any pathology on brain arteries. That's interesting. So the brain usually is spared. The arteries of the brain are never affected in ENPP1 deficiency. I'm not so sure about PXE, but I'm sure that there are no aneurysms, no brain aneurysms in PXE patients. Regarding your second questions, yes, we have found at least one patient with ABCC6-related generalized arterial calcification of infancy, where we found hypophosphatemia in the early, I think it was in the second year of life. The thing is that it's not often measured, and you don't often know. But we have at least one patient where we are sure that he also has phosphate wasting. And going back, the phosphate wasting is very interesting because it seems that if you have ENPP1 deficiency, you can have phosphate wasting without calcifications. This has also been found by two groups independently. So there is an ENPP1 related hypophosphatemic rickets phenotype.
Right, and I think
So,
if it
we need to cut this
here, the common mechanism here may be a relationship of inorganic pyrophosphate to phosphate handling in the kidney. The reason I say that is here's an example of low pyrophosphate renal phosphate wasting. After lunch, I'll tell you about the opposite disease, and that's high pyrophosphate levels characterized by hyperphosphatemia, enhanced renal reclamation of phosphate. So there's this beautiful relationship at the kidney level of conditioning excretion of an inorganic pyro and inorganic phosphate.
Very interesting.
Last question.
Have you measured pyrophosphate in the plasma of PXE patients?
Not yet.
But you're going to.
Well, if we have the samples, it's very difficult to measure pyrophosphate in plasma. You have to have a strict protocol to get the samples. In urine, it's also difficult for the collection of samples. That's difficult.
I see.
Yeah.
Thank you.
You'll have to sit at that little bench.
Okay, just one quick one.
Similarly, trying to get at mechanisms for both of these, I wondered if the response to bisphosphonate in the ABCC6 is any different than in the ENPP1.
I don't know. Actually, there have been patients treated with ABCC6 deficiency and bisphosphonates, but I don't know the outcome yet. And it's difficult to really say that bisphosphonate treatment is beneficial at all, because there are so many spontaneous resolutions of the calcifications as well. We found this in a retrospective trial, that the survival seems to be increased in these patients, but there's no randomized control study, of course.
Thank you very much, Baruch. Great.